Thanks for being here today. I wanted to start with a quick story. A few years ago, I got a call from a clinic pharmacist who was practically in tears. A patient with metastatic lung cancer had just been denied coverage for their oral chemotherapy. Why? Because a prior authorization form hadn't been submitted correctly. It wasn't a question of clinical need or evidence, it was paperwork delay. And that patient's treatment started almost 2 weeks late because of that. Unfortunately, this is not a unique story. Prior authorization is supposed to be a tool to make sure care is appropriate, evidence-based, and cost-effective. But in practice, it's really become a major pain point for providers, for health plans, and especially for patients. Today, I wanted to walk through what prior authorization is, how it works in the US, why it's so controversial, and where we're headed. I'll bring you both the data and the human side, and I'll share some of my own experiences working inside managed care and evaluating policies for Medicaid and commercial plans. My goal here is not to take sides, but is to help us think more clearly about how we balance the cost control with timely, appropriate access to care. So let's start with the basics. What is prior authorization and why it exists? Prior auth, or PA, is a cost containment tool that is used by health plans to evaluate medical necessity of certain treatments or services before they are approved for coverage. In the US, prior auth is used across Medicare, Medicaid, managed care plans, and most commercial insurance plans as well. It was originally designed to reduce inappropriate prescribing, prevent unnecessary procedures, and guide clinicians towards more cost-effective care. And I can say from my experience, there are inappropriate prescribing events, there are unnecessary procedures, and there are less cost-effective care. There are, for example, brand names of metformin, a drug for diabetes, that are incredibly expensive, and you could just take the regular extended release metformin rather than the Glumetza, which is a super stupid, expensive version that adds no clinical value at all. Anyway, the Center for Medicare and Medicaid Services, CMS, defines prior authorization as a utilization management strategy to ensure services are furnished in a way that aligns with evidence-based guidelines and promotes value. But, as we'll see, while the intent is aligned with quality and cost goals, the implementation often falls short for patients and providers alike. And my information here was based on the Center for Medicare and Medicaid Services in 2023. All right. Looking at the AMA Prior Authorization Reform Principles document from 2022, we can find that the process here usually starts when the provider submits a prior authorization request to the insurance plan, and this includes documentation, clinical notes, and any justification or treatment for the medication. The request is then reviewed by the payer, usually clinicians employed by the payer, against their own internal guidelines, which may be based on clinical guidelines like NCCN, DrugDex, or AHRQ guidelines, or sometimes they can be really opaque internal algorithms. Depending on the urgency, decisions are supposed to be made within a certain time frame. For example, CMS requires expedited decisions be made within 72 hours. Commercial plans can vary widely. And just from my experience in California with managed Medi-Cal or Medicaid plans, you have to make a decision on all requests within 24 hours, even on weekends. So technology is catching up though, and many providers now use electronic prior auth systems like CoverMyMeds, SureScripts, but fax and phone calls are still painfully common in a lot of practices. It's important to note that while the administrative side of prior auth is often emphasized, clinical criteria driving approvals or denials are equally critical and often misunderstood by frontline providers. Now, here is where things get complicated. According to that AMA 2022 survey and an OIG report from last year, the current prior authorization system creates significant friction in clinical care. According to the American Medical Association, 88% of physicians say that prior auth delays access to necessary care, and more than 1/3, over 33%, report that delays have led to serious adverse events for patients who have not received their medication. The U.S. Office of the Inspector General reviewed Medicare Advantage plans and found that 13% of prior authorization requests were initially denied, many of them wrongly. Even more troubling, the same report found that most denials were overturned on appeal, suggesting that the original decisions were flawed. Now, I could speak a little bit to this. So when you get a prior authorization request and we require additional information, let's say lab values, but we haven't gotten those lab values. We request them, but we still have to make a decision within 24 hours. So if we haven't gotten those lab values, we end up denying it, and we have seen in practice where the doctor's office will get the denial with the reason for the denial saying, hey, we need lab values, please send them in. They send them in, and then we, approve it because we finally got those lab values, which for some reason they couldn't just send to us when we originally requested them. Now, to be fair to them, they didn't. Well, some of the meds you should know exactly what lab values are necessary, but the system is not exactly optimized to make sure that that communication between the plan and the provider is optimal. Beyond the data, there's a human cost. Patients waiting on cancer therapy, kids denied behavioral health treatment, or in my own work, I've seen delays in access to hepatitis C treatment in Medicaid because of rigid step therapy policies embedded in prior authorization protocols. These burdens don't just affect patients. They create strong burnout among providers and absorb enormous amounts of staff time, and a lot of providers will actually even have their own, a staff member completely dedicated to prior authorization. There's a growing recognition that at both the state and the federal level that the current prior authorization system needs reform. At the federal level, CMS finalized rules that will require real-time electronic prior authorization processes for Medicare Advantage, Medicaid, and the CHIP Act by 2026. This is a major step forward in terms of transparency and automation. Meanwhile, states like Texas have passed the Gold Card legislation, where providers with a high prior approval rate are exempt from prior auth altogether for certain services, and I think that's a great idea. In practice, usually when you have a specialist in a certain area, let's say a GI doc who's writing for a certain GI medicine, they know what they're doing. And in practice, even though we couldn't have coded it in there, we just approved those when they came through because we trust the doctors to know what they're doing. California's Senate Bill 250 proposes timelines and penalties for plans that fail to meet response deadlines. There's also bipartisan support, one of the rare things that has bipartisan support, for the Improving Seniors Timely Access to Care Act, which would codify timelines and expand access to electronic prior authorization in Medicare Advantage plans. Professional associations like the AMA, American Academy of Family Physicians, and MGMA are lobbying hard for these changes. It's not just a way to reduce administrative burden, but it's also to improve patient safety. So, what's the solution here? How do we preserve the benefits of prior authorization, like cost control and safety, and like I mentioned, that is absolutely necessary. I've seen some things that are very scary, without harming patients. First, criteria should be aligned with trusted evidence-based guidelines. For example, NCCN for oncology, AAHQ for procedures, and clinical guidelines distributed by professional organizations for other medications. Second, automation and AI clinical-based decision support can dramatically reduce low-value prior authorization requests. This is something I have done before, is I have built decision support systems, and so it's for prior authorization for technician review, and technicians cannot deny requests, but if they meet all of the criteria, then the technician can approve it right away, and that way a pharmacist doesn't even need to do it. If we could auto-approve a statin refill, for example, we absolutely should. Third, more collaboration between payers and providers. That includes sharing data, publishing approval criteria, that's the really big one there, and enabling feedback loops. There's just really not a great way for providers and payers to communicate right now. And finally, we can't forget the patient. Patients need clear, timely communication when a prior authorization is denied. and access to appeal options that aren't buried in a 20-page document. Personally, I've seen how these changes can work. At one health plan, we reduced prior auth turnaround by over 40% by simply automating some high-frequency drug classes and improving transparency with provider. It's possible. It's really just going to take the will to change. Thanks so much. I used some guidelines here from AHRQ, CMS, and NCCN. I appreciate you watching.